Welcome everyone. In this episode, we are discussing resistance training for type 2 diabetes. And we have a brilliant guest for this episode. Our guest is working as Associate Professor of Wellness and Health Promotion in Oakland University. And her research area is in exercise and diabetes with a special focus on resistance exercise. Ladies and gentlemen, please welcome our guest, Professor Elise Brown. Welcome, Elise.
Thank you so much for having me today.
Yeah, great to have you. So, should we start? Do you want to introduce yourself and share a little bit of background, how you went to resistance training, research, and so on?
Sure. Yeah, I have been involved in weightlifting as soon as I was old enough to go into the church gym and use it by myself. So that was probably about 14 years old. I was always involved in sports growing up too, mainly basketball and softball, and during school, weightlifting ever since 14 was incorporated as part of our training. When I'm originally from Louisiana, did my undergrad at Louisiana Tech, master's, I moved out to Texas at Midwestern State University. And that's where things really started coming together for strength training, weightlifting, with that being a key focus of my career. One of my mentors, Dr. Lon Kilgore, he had an Olympic-style weightlifting background, and I was telling him I was starting to get interested in being a strength and conditioning coach. And he told me that the first thing that I needed to do was learn the Olympic-style lifts. So he sent me back to Louisiana State University in Shreveport because they've had one of the best weightlifting programs in the country for quite some time. So what was supposed to be a 3-month internship turned into a 2.5-year internship because I started competing, really got into it, loved the sport. And after being mentored in weightlifting and powerlifting by competitors and coaches in those fields, that took my skill set in terms of doing all the lifts to a whole nother level. And so weightlifting has always been a passion of mine. I competed in it for 6 years. I moved to Scotland to do my PhD. I competed in weightlifting while I was over there too. And my PhD focused more on, I was evaluating a Scottish health intervention that they had developed for kids and implemented them in schools. And so that was my first hand at getting experience in cardiometabolic outcomes, so measuring cardiometabolic outcomes. And when I started at Oakland University, which was back in 2015, it took me a couple of years to figure out exactly the niche area that I wanted to go into research-wise. And I knew that I wanted to have strength training be a part of it. And my dad has type 2 diabetes, and so the type 2 diabetes is a bit close to home for me. And after speaking with one of my mentors from Scotland, Julian Baker, he had suggested, he's like, why don't you just work on the resistance training guidelines for people with type 2 diabetes? And as soon as he said that, that sounds perfect. That's exactly what I want to study. I'll be able to help my dad in doing this. It gives me an opportunity to learn more about something that I'm absolutely passionate about. And so that's how I got into it. That was probably about 6 years ago that I started narrowing my focus in strength training and type 2 diabetes. And so since that point, my research team and we've established grip strength cut points for estimating type 2 diabetes risk in adults, and then separately did the same thing for estimating cardiometabolic risk in youth. We've done a systematic review and meta-analysis on interventions, resistance training interventions in people with type 2 diabetes and looking at cardiometabolic outcomes. Also did a narrative review on acute studies, so looking at single bouts of resistance training and how that impacts cardiometabolic outcomes. Got a few things in the works right now and some really exciting upcoming opportunities. So yeah, I'm excited to keep moving forward. And yeah, I definitely found the area that I was meant to be working in.
Yeah, sounds really nice. And I think there's so much, maybe it's history, that there's so much research on cardio training, and strength training is very important, but it's just somehow there's much less research. And I have done my degrees in University of Jyväskylä, and there was the head of the department was Keijo Häkkinen, who has been doing quite a bit strength training. So also the teachings were of course, a little bit more than strength training when there was tradition of doing strength training. And I did also, I was a research assistant in some strength training studies. So I've been there we had a fatigue protocol for the quadriceps. And then after that, we had to stimulate the nerve. And that was brutal. The persons were really tired. And then maximum stimulation during MVC. And it is interesting. Let's
imagine.
say so. Yeah. But if we go then to type 2 diabetes and strength training or resistance training, what are the most significant benefits of strength training?
Yeah, so the first thing that comes to mind is going to be muscle hypertrophy. So in type 2 diabetes, one of the unfortunate consequences of type 2 diabetes is muscle wasting. And so being able to rebuild that muscle tissue through strength training, that's going to be imperative for increasing more metabolically healthy tissue throughout the body. And then another part is because of that muscle wasting, and also as we get older, there's going to be decrements in muscular strength. So this becomes even more important for older adults with type 2 diabetes, is that strength component of strength training. I'm a huge advocate for doing exercises that mimic everyday lives so that it does enhance the functional capacity for older adults or anybody to be able to do just normal activities of daily living. So that strength and power aspect is going to be specific to resistance training, which is really important for diabetes. And then also with neuropathies fairly prevalent in people with type 2 diabetes. And strength training, when done in a specific way, is an effective. And so with neuropathy, one of the main challenges is people start to lose their balance, right? There's nerve damage in the hands, there's nerve damage in the feet. And because of that, they tend to lose their balance. So strength training, specifically when you're doing a lot of standing exercises that work the legs, that work the core, and specifically unilateral leg exercises like lunges, those are going to be really helpful in improving those balance decrements. It's also really important for increasing bone mineral density as well. And then it can also be used, so in people with type 2 diabetes, there does tend to be a higher prevalence of sedentary behavior. And with that sedentary behavior comes a decrease in flexibility. If those joints aren't moving, it's going to get tighter and tighter. And strength training, when done properly, when it's taken through a full range of motion, it's a dynamic stretch. So if you think about a squat, if you have somebody squat down as low as they can safely go and then come back up with just their body weight, just an air squat, you can have them work that range of motion through doing the squatting movement.
Yeah, makes sense a lot. And you said hypertrophy, so more muscle mass, it helps with the activities of daily living. Do you see it as you can also view muscles as an organ? It's excreting different hormones, it's affecting the hormonal balance of the body. Do you see important from that perspective also?
Yeah, and that's also going to be related to, let's see, the intensity of the movement. And so that's one of the things that separates some of the mechanisms and the adaptations from traditional aerobic exercise, right? So with that higher intensity, there's going to be greater hormonal adaptations, and there's that higher intensity also has effects on insulin signaling as well.
Yeah, and you already said it a little bit, but then if we compare aerobic activities and strength training in managing or preventing diabetes, how are the differences?
Yeah, so they do what we've seen with, other than what I've already mentioned with the muscle hypertrophy, strength, all of those are specific to strength training, not endurance training, right? Or aerobic training. And yeah, it's mainly like one of the main differences, like I was saying, is going to be the higher intensity level of the strength training versus aerobic training. But in addition to the insulin signaling part of what happens with that higher intensity too, and I haven't read too much about this, but I know that there's also an activation of signals that are related to, an activation of sensors that are related to improve calcium signaling and muscle remodeling as well. Let's see. And Yeah, one of the challenges too is with the cardiometabolic outcomes, they're really similar in terms of what resistance training does and what aerobic training does. Both of them improve endothelial function, blood pressure, blood lipids, glycemic control, insulin sensitivity, all of it. And it's difficult to parse them out in the longer training studies because a lot of the resistance training interventions in type 2 diabetes, they don't control for aerobic fitness levels before and after the intervention. So we don't know at the end of the intervention what was really a result of the resistance training itself, or was it muscular fitness that was improving primarily that was causing these adaptations, or was there a change in aerobic fitness? We don't know because a lot of it has a lot of the studies don't actually measure that.
Yeah, now that's good. And then if we think about, you can do resistance training quite many different ways. You can do hypertrophic training, you can do neural training, you can do it as a circuit training when it's more about cardio. What kind of studies have been done with different resistance training protocols? Is some form better than the other? What does the research show at the moment?
So when we did that meta-analysis in people that were at risk for type 2 diabetes, we didn't have enough studies to run a meta-regression to see what program characteristics were associated with effectiveness, but we did look at the studies qualitatively to determine the studies that were effective in improving cardiometabolic outcomes. What were the common intervention characteristics that we saw? So from that meta-analysis, we found that in terms of frequency, most of them were at least 3 days a week. And so this is traditional resistance training. We didn't include circuit training or conventional resistance training, I would say. With intensity, what we saw, and with intensity, that's going to have a direct impact on the number of repetitions that you do, right? If you do higher intensity, then you're not going to be able to do as many repetitions. Low to moderate intensity, you can do more repetitions. So what we saw was in the studies, most of them had rep ranges between 10 to 15 reps, and the intensities were over 60% of 1 rep max. I'm not saying that protocol is going to be the most effective because we were just restricted to the studies that were included in the meta-analysis, because I think it's common to prescribe the higher rep ranges a lot of times with populations that have chronic conditions because there is that hesitancy towards safety whenever we're talking about the higher intensities. But there has been some data suggesting that the higher intensity and the lower rep ranges are actually more effective at improving insulin sensitivity than these higher rep ranges. There was a study that came out a few years ago by Black and colleagues, and this was in people that had prediabetes. And they were comparing multiple sets at 85% of 1 rep max versus multiple sets at 65% 1 rep max. They matched the workloads, and they found that there were greater improvements in insulin sensitivity from the higher intensity, the 85%. So when I'm saying 10 to 15 rep ranges at higher than 60%, that's only based on the studies that we had in our intervention. It doesn't mean that it's the best way to go. And then we also found, just looking at modality, so people use different modalities in terms of free weights, resistance bands, machine weights. All of those were effective. So we didn't see any type of differences between those types of modalities. And then the ones that were doing full body intervention protocols, with most of the exercises being multi-joint exercises.
Yeah, so interesting. And I wouldn't assume that there's a difference between modalities. The body doesn't really know what you are doing the exercise against. If you just have the intensity, it probably doesn't make a difference. And about the mechanism, so is it about activating as large muscle mass as possible? I would assume that's the kind of the stimuli for the body. And do we know anything about, like you said, that probably you think that the higher intensities are better? I would guess the same, but do we know what is the pathways? What is the effect? Why is the high intensity better than the lower intensity?
Yeah, and I think that with the higher intensity, that kind of goes back to what I was saying earlier with improved insulin signaling happens at higher intensities, and then also the greater activation of those sensors related to calcium signaling too. So that, and also I wish I had the name of this meta-analysis, but there was a meta-analysis that came out, I think it was in 2022. So they did look at, this was type 2 diabetes, intervention studies, cardiometabolic outcomes, but they looked to see if changes in muscular strength was the moderating variable for greater improvements in glycemic control, and that is what they found. So the higher the levels of muscular strength that was increased over the course of the intervention, there was a greater impact on glycemic control. So when I hear greater increases in muscular strength, to me that points to intensity again. It's also going to be it'll really be a combination of frequency, intensity, and total volume, so overall work they're doing. But the initial thought is if they're going to have higher increases in muscular strength, that's going to be directly related to intensity. The main mechanisms that I've seen so far with that higher intensity, it's been improvements in insulin signaling. And yeah, when we're talking about differences in the modalities, once again, there are differences in terms of neuromuscular adaptations across the modalities, because when you're doing free weight exercises, especially when you're doing them from a standing position, the entire body's engaged and you're recruiting a lot more stabilizers. So yeah, I'm not sure if there's much of a difference in cardiometabolic outcomes, but certainly functional outcomes and performance outcomes I would expect across different modalities.
Mm. Yeah, and I think it's a good point what you said earlier, that the 10 to 15, the meta-analysis, so that's maybe the best one because that's what the studies usually do for the safety. I think it seems to be quite true for the many different things that strength training, it's probably to do with the higher load, higher intensity, even if the studies show a little bit lower, because yeah, most of the studies are done with the little bit more repetitions. And if we look, you have also done studies related to women and underserved populations. What are the kind of the challenges for them accessing resistance training programs?
I think self-effort, like from my experience, and I work with a lot of university females. So I'm a professor and I try to integrate my research into the classroom as much as possible. And the one way that I do this, which is my favorite part, is one of the labs that I teach is it's a health and fitness assessment lab. So for muscular fitness, that topic, we spend 3 weeks in the strength lab and I'm teaching them how to do 5 rep max testing and 1 rep max testing, and only focus on 2 exercises, the back squat and the bench press. And I break these exercises down as much as I possibly can so the students have a really firm understanding of these 2 exercises. We practice them for 3 weeks because I know that my skill set is quite unique with the Olympic style weightlifting training that I've been through. And I want to be able to share that in my job and be able to incorporate it as much as possible. And what I hear from a lot of and most of my students are females, and what I hear a lot from them is later on in the semester is, Dr. Brown, I've been going to the rec now and I didn't know how to do these exercises before, so I'm feeling a lot more confident. So I think that self-efficacy is a huge part with women in general, because I'm sure this as well, physical activity in general, females are less active than males from cradle to grave. So this is really a cultural thing. And so some other things concerning women is, if we're talking about some of the psychological variables, depression. Women tend to suffer from depression at a rate that's 2 to 3 times higher than men. And if you're too depressed to get out of bed, you're less likely to actually go lift weights too. There's cultural differences that women have to face too. Now, there are some cultures that discourage any type of exercise for women other than just walking, but in the US, I have definitely noticed a cultural shift in terms of muscularity being more accepted by females than it used to be. I think that CrossFit had a big impact on that. Yeah, there's just There has been a cultural flip, I think, to more acceptance to muscularity in females, which I am totally on board with. So there's that dynamic as well. But there are still a lot of females who are afraid of bulking up. My first job when I graduated with my undergrad was a personal trainer, and the majority of females that I trained, they always wanted to lose weight, tone up, but they didn't want to bulk up. That was typically the three main points that they gave me. And what's interesting about that, and this is something that I remember having discussions with my former mentor, Lon Kilgore, about, is most personal trainers, and I used to do the same thing, in this situation, they typically have the women doing 8 to 12 rep ranges. 8 to 12 rep ranges, it's great for fat burning, but that's also a hypertrophic range as well. So it really makes more sense if that's the fear if the fear is to bulk up, why wouldn't we increase the intensity and have them doing fewer reps, like maybe between 6 to 8 reps, where there's going to be less of a hypertrophic effect and you're going to have increased muscle tonus, right? So like muscle tone, that's just increased electrical activity within the muscle. And you're going to get a greater degree of that with the higher intensities. And then the last thing, and this is more for adult women, but the social roles in terms of familial obligations, the expectation is that women put themselves behind the rest of the family, right? So always put the family first. And so that can a lot of times translate to the mother not taking care of her fitness needs and having her health decline. And it becomes even more challenging when kids are in the picture. So if they have, or whenever there's more than one child, that can present a financial burden, which they might not be able to purchase a gym membership.
Yeah, good points. And I think the bulking up, I think it's very common, and it's maybe not always the thing you should be afraid that if you go twice a week for half a year that you suddenly become like huge. It usually doesn't happen easily for bodybuilders. They put quite a bit of effort growing and so on. But yeah, that's quite common. And how do you see the role of researchers and practitioners? How should they be supporting these groups to help them engage better in strength training?
Yeah, and I forgot to mention some of the barriers for underserved populations like lower income people or people that live in low income areas. So part of that dynamic or a specific barrier is going to be lack of facilities, lack of fitness facilities, and they might not always have transportation to get to those facilities, especially if they live in a rural area. So research-wise, the first thing that I wanted to mention was environmental influences. So what type of environmental impacts influence resistance training behavior? When you look into the environment and physical activity literature, very little research has been done on how the environment impacts resistance training. It's all related to general physical activity. And most of those studies have been done in primarily in urban white populations. So we first need to actually start studying the underserved population, so racial minority groups, as well as people that live in rural areas where there are fewer opportunities or fewer facilities for them to train at. So one of the studies that we did a few years ago, we actually developed a questionnaire that measures how the environment influences resistance training behaviors. And we measured 3 main environments or 3 main dimensions. First being the home environment. So do you have any resistance training equipment at home? And what we found is those that had resistance training equipment at home, they were more likely to meet the muscle strengthening guidelines. The other environmental dimension was the social environment. Do you have friends that lift weights? Do you have family members that lift weight? Do you have somebody in your life that supports you and understands your challenges around resistance training? And once again, similar to the physical activity literature, more social support for resistance training, more likely to meet the guidelines. And the last one had to do with facilities. So we were asking if they had a fitness facility that was within a 10-minute drive or a 3-mile distance from their home. And that parameter, again, those that indicated that they did, they were more likely to meet the resistance training guidelines. So I think starting off by studying these areas more related to environment, that could be a good start. And really, when we're talking about adult behaviors engaging in resistance training, think we need to start a lot earlier on in youth. Like my PhD, I'd focused mainly on primary school age children or elementary school age children. And a lot of the health behaviors that are developed in childhood, they track into adulthood. So if we could focus more on quality PE programs within schools, rather than telling them they need to get in 60 minutes of physical activity every day, actually providing them with the opportunity so that they can build that physical competency or physical literacy, specifically with resistance training, that's going to have long-term implications for them. And then if we're talking specifically about women, I think a lot of gyms do this really well in terms of having childcare facility options, but I think having those types of support services are quite meaningful.
Yeah, makes sense. And then maybe a little bit about the future of research. What kind of studies you think we need to understand the resistance training's role in diabetes, prevention, management, and maybe also other chronic diseases?
Yeah, so I think the components related to prescription need to be studied more in acute studies. And what we really need to start doing a better job of, too, is reporting intervention characteristics in the research. I was really surprised in the meta-analysis and the review that we did that there were some studies that didn't even mention the exercises that they did. They were as vague as saying, we did upper body exercises and we did lower body exercises. Rest periods were left out a lot. They didn't report how much time was spent resting in between exercises and in between sets. Another intervention component that is, I don't think I saw it reported in any of our studies that were included, and I think the research is a bit more newer on this, but movement speed, so how fast you're actually moving. Because what's interesting is that there are movement speeds that are associated with greater impacts on insulin sensitivity. Can't remember which one it is. I think it's the 2-second eccentric and the 1-second concentric, but there is research surrounding even movement speeds that can impact these cardiometabolic variables. Let's see. So learning more about medication interactions with resistance training. There's been a decent amount of work done with aerobic training and adjusting insulin dosage for people that are using insulin. But in that acute review that I did, I think there were only 1 or 2 studies that looked at it with resistance training. And one last thing I would say is understanding the time course of beneficial effects. So that was another point from that review that I did was, like with aerobic training, we know that, the beneficial effects on fasting glucose can extend up to 72 hours after the exercise session. But when we looked at resistance training, all of the studies that found any type of significant improvement immediately after the resistance training bout, they only measured up to 24 hours after the session. So we don't know how long the beneficial effects last with resistance training, and that's going to be important for determining training frequency.